You're listening to the OCD Stories podcast, hosted by me, Stuart Ralph. The OCD Stories is a podcast dedicated to raising awareness and understanding around obsessive-compulsive symptoms. I do this through interviewing inspired therapists, psychologists, and people who have experienced OCD. Welcome to the OCD Stories. And welcome to episode 479 of the podcast. And in this one, I got back on Jonny Say. Jonny is a UK-based therapist and co-director at the Integrative Centre for OCD Therapy. And this episode is all about ideas for when people struggle with therapy for OCD. And in particular, he covers such ideas as the length of therapy, he normalises the time frame, trying other approaches, therapists, or a combination of therapies, increasing motivation through active reflection, building up skills around psychological flexibility, self-compassion, and much more. Jonny does a really good job of giving a lot of ideas and things to think about that hopefully could help you if you're feeling a bit stuck in therapy currently. Struggling with OCD? You're not alone. NoCD offers live, face-to-face video therapy with licensed specialists who truly understand OCD. NoCD therapists are trained in exposure and response prevention therapy, the gold standard for OCD treatment, and provide personalised treatment and support for children and adults. Take the first step towards regaining your life today. Visit nocd.com, or the link will be in the episode description to book a free call. So thank you to you guys, as always, for listening. It means a lot, and I mean that. And thank you to Jonny for his time and expertise. Always a pleasure to chat with him, and I'm glad he could talk on this topic. And without further ado, here he is. Welcome back to the podcast, Jonny.
Hi, Stu. Good to see you again.
Yeah, it's good to have you back on. So before we get into today's topic, what's new with you? Obviously, I know, but it'd be good for the listeners to hear.
Yeah, I don't think I'm going to shock you here, but we're still obviously doing a lot with the Integrative Centre and sort of developing our offering there, working with our team of therapists that we really think are people with a high degree of experience of working with OCD and have been really trained in useful approaches for therapy, and particularly on the topic I'm going to talk about a bit today, when people are struggling and having a difficult time with it. But then beyond that, I'm doing my 10-week course still, the ACT skills for ERP and OCD recovery, and the monthly review group that I do for people who've attended that and for our clients. But then the big thing I've been developing is a training actually for clinicians. So I've been thinking about my own experience of OCD recovery, what's been helpful for me, what I've learned from different specialists that I've either had supervision or been trained by, a lot of people in the ACT world, the likes of Russ Harris and Steve Hayes, people like that. But then particularly actually what I've learned from my clients and what barriers they've hit, things that I've also struggled with, the ways our brains resist recovery, and then, trying to condense that into a training for clinicians, which works through a sort of progressive run through of the ACT skills that I think can really support ERP, the compassion skills that help with the shame aspect, and how to sort of hopefully teach people how to do that.
Yeah, that's cool. And that's live, right?
Yeah, it's going to be a live training on the 25th of April. You can see it on our website. We've got a tab now that has all the live trainings, and so you can have a look there or reach out to me with any questions about it. Looking forward to it. It's going to be fun.
Yeah, nice. I'll dig the link out and stick it in the show notes for any therapists interested in learning more about ACT or going deeper with ACT for OCD.
Right.
Cool. So, I guess we're going to dig into some of those points today anyway, but more for people listening with OCD rather than the therapists. But I'm sure it'll be interesting to the therapists too. So, the topic is, people who struggle with therapy for OCD. And are you going to focus more on the way you do ERP from an ACT lens, or will this apply to also people just going through regular ERP?
So I'm thinking about different degrees of struggle here. I think that I'm not really thinking of people that are getting good results from ERP in a sort of more traditional CBT lens, and maybe people who are new to recovery and are going into that approach and hopefully going to benefit really well from it. I'm thinking more, I guess the categories I had in mind are the clients that reach out to me a lot, the kind of client group that I see a lot. So some of them, are people that have done ERP or are doing ERP, and it's somewhat helping, but not as much as they would want, or, it's taking longer than they'd anticipated. Um, it's people that have benefited from ERP that might have relapsed, people who are fearful to actually engage in ERP, and it's kind of off the cards, off the table for them in their mind. People that have had multiple rounds and lots of different therapy, and it's not been helpful. Some people that it's been too intense, they've been escalated into something very intense right away, and it might have had negative impacts and left them in a worse place. And then other people that it's been dormant for a long time, and then it might have come back and they're dealing with, oh, here it is again. So those kinds of struggles I'm thinking of today, really.
Okay, brilliant. And I guess why focus on this? Is this something you see a lot of in your clinical practice of adults?
Yes, I am passionate about this topic because, I'm a big believer in ERP. ERP is awesome and helps lots and lots of people. But I think that sometimes the way it's portrayed to be a very systematic and predictable, therapy with specific outcomes and specific timelines sometimes trips people up, that their recovery is much messier than that, and that perhaps isn't so predictable. So I have a lot of people reaching out to me with that presentation because they've heard me talk about ACT as something to help with things like mental compulsions and intense feelings and shame and other things like that. So I'm, I guess, biased to this client group because it's all I see, really. All my clients fit this category. And so, I'm always trying to think how I can help these people more and what I can do to sort of give some other options when things aren't so helpful. So yeah, I'm really passionate about it, but don't hear any of this as, saying ERP isn't fantastic and isn't the first place to start. And, for a lot of people, it's going to be very, very helpful. But I guess, I'm thinking that there's people that it isn't quite as simple as that for.
Yeah, well, exactly that. Well, that's the whole, my criticism, and well, not mine, many people's, of any kind of manualized therapy, which CBT is sometimes. Trial sessions that we can get symptoms right down. For a lot of people, that's not the case. There's a lot of factors and things that get in the way that need work. And, a problem that's been developed over many, many years or decades, it's not unreasonable to think it might take more than 12 sessions.
Well, exactly. And, I think your fantastic podcast really tells us this, because if you go back over the back catalogue of stories, there are some incredible stories where people have come from really tough places and got to really good places. And many of them are your friends and my friends and other people in the recovery world. But it was never a simple process. I can't find the stories where it's a short space of time and very predictable recovery without any resistance, without any setbacks, without any theme jumping around or other issues coming up, or having to deal with other things like the grief and the shame and the other aspects of OCD recovery. So I just don't think those simple stories are out there. I've never talked to anyone that has had that and then it's been a long-term thing. And I think, a lot of people are not saying that. They're saying this is an incredibly helpful tool to get symptoms down and to sort of get your life back. So it's not like people are all saying that, but I think there's mixed messages in how it's sold. Because it's so effective, people really want to emphasize that because they want to put that positive outcome, message in people's minds as they begin. And that makes complete sense. And I think, that can be a helpful way to approach therapy. But for people that it is much messier and much more like a roller coaster, they then either start to blame themselves or they blame the therapy. They think it won't, it's the therapist's fault or my fault, or that I'm some way, can't be helped. And actually, it's just a much more normal thing for it to be a roller coaster. My own journey, I mean, I've told some of my history here before, but if I think about the treatment section, I think mid 2000s, I started to realize intrusive thoughts and OCD is what I've been experiencing all my life alongside, some of the stuff I'd experienced. I knew panic and depersonalization. I knew that's what I had, but I didn't know about intrusive thoughts. So I kind of discovered that then. And then it took me quite a few years to then engage in therapy. And, 2013, 2014, I was starting to have therapy and ERP. And then it wasn't until 2017 that I really had significant shifts. And to me, as I've told all my story other places, it was really bringing in ACT and the acceptance sort of approach to ERP that was the most helpful thing. But that's a long time, that's a long journey. It was up and down, it got better and then it got steadily worse and worse and worse until I really hit rock bottom. And then, it sort of improved from there. So it's messy, right? And that from your history, right, as well. I'm sure you'd say the same, right?
Yeah, it's very similar. And yeah, I don't want to say, you can't make a lot of progress in 12 sessions. You can. And I've had clients, especially young clients, and teens that make incredible progress in 12 sessions. But I think for a lot of people, it can be disheartening when you think it should be a quick fix CBT, and it isn't always a quick fix.
Yeah, totally. It can be very effective in short periods of time.
Yeah.
But then you don't always know what happens over the long term. And, even if those studies have a follow-up of a year, okay, what happens after that? And also, how do you extract, OCD clients wanting to be good patients? And, if you're having self-report, like how does that really match on to someone's actual life versus wanting to be a good client? And, there's like a lot of messiness in that, really. So, that's why I think the missing ingredient of sort of that long-term study of people's journeys from the person, the person-centered sort of approach of someone really sharing that over the long term has to complement the quantitative data. You need the qualitative to expand the quantitative.
Yeah.
I think your podcast does that, right? That's what your podcast is doing, and obviously not in a formalized way, but it is doing that, and so yeah, I think you don't always get that, and like if you'd interviewed me at the end of my first couple of rounds of ERP, I'd have been very positive, and even follow up, I might have been pretty positive because I was trying to stay hopeful. All the while, things were actually getting worse. So, it can be complex in how people report these things as well. And again, not to say it can't also be simple and work very effectively like you described. I've seen those cases and, and work with those people too. But it's just, I guess I don't want to do anything that undermines the message of how useful ERP can be, but I just want to validate the experience of people when it's messier and, takes longer, or, it gets very complex and shifts and shape shifts and becomes, more difficult. I just want to really normalize that. And I guess that comes from my own experience. And then it really does come from the clients that are reaching out to me, because I'm hearing from people like this often weekly, often multiple people a week, sometimes large numbers of people. So, there's lots of people going through this, and my heart goes out to them, because if you've tried ERP and then you've had the intensity of your intrusive thoughts, of your overwhelming feelings, of your dissociation, depersonalization, things like that have gotten worse, and then someone said, no, you just got to keep going, you got to do more, and you've done that and it's still continued to get worse. And then you might have been told, well, you're doing it wrong, or you're still doing compulsions, you're still doing this or that, and it's kind of the blame's pushed onto you, my heart goes out to these people because, actually it's more complex than that, as we're learning with the interaction with trauma and other things. And so I want to have some ideas for that. So yeah, the first idea really is the normalizing and the validating of that, which we've talked about there. The second one is to try other therapies and other approaches. So, different clinicians within ERP will emphasize different blends of the treatment components. Sometimes people will be very heavy on, more behavioral exposures, more imaginal exposures, more cognitive work up front, less cognitive work up front, more core fear work, less core fear. People will have different blends of this approach, and they'll have different specialist subtypes and specialist client groups and things they work with. So it can be worth just trying, different approaches, as I did. And then, then potentially trying some other treatment approaches, like, we're big advocates of ACT and compassion, but equally metacognitive therapy I like a lot. And obviously you've had a lot of ICBT people, and I definitely really appreciate a lot of the psychoeducation out of ICBT, and I'm exploring it to see, what I make of other aspects of it. So I definitely think it's worth exploring these things. And Kim Quinlan's integration with CFT, and John Hirschfield bringing in lots of DBT, dialectical behavior therapy. I think trying some different takes on it, and seeing if any of them resonate more. If you've got trauma in the mix, maybe trying another type of trauma therapy that you haven't done. So I think that's the first one, right? Is not giving up just because you had the experience with one or maybe even two therapists that was a bit invalidating.
Yeah, I mean, I've read many times in comments like, I've tried everything. I'm like, you've not tried everything, because there's infinite amount, not to discredit, but it's like there's infinite amount of combinations, and you haven't even tried every therapist, because every therapist has their own approach, tweak on ERP.
Yeah.
It's infinite. So
and how they land with people, right? Not everyone's going to resonate with me. I've certainly had clients that have ended with me early, and I haven't quite known why. And it's probably that and they wouldn't tell me when I asked for feedback and things. And it's probably aspects of my personality or the way I do this that didn't. Stu's laughing because there's plenty of aspects of my personality he finds challenging, but maybe not in the therapy room. So yeah, I mean, I think not everyone I think sometimes the therapeutic relationship can be over. There's a lot of researchers that sort of say it's the most important factor. I think a lot of the traditional ERP researchers would debate some of that research, but I don't think they would debate that it's an incredibly important, up there with the method that you take, and so it is important to get a therapeutic relationship that works with you within CBT. And it's talked about a lot in CBT. In all the textbooks I read in the NHS days when I worked there, they talked a lot about core conditions and therapeutic relationship within the CBT books. So getting the right relationship is key. And if you feel patronized and blamed, find someone who's more compassionate. If you find someone's too they're not specific and clear enough for you, they're too vague, find someone more specific. You can work to find the right person for you, I think.
100%.
Yeah, the next one is a big one for me and the clients I work with, is massively increasing motivation through active reflection. So to keep this really simple, I tell people to try and 50 times a day think about your motivation for recovery. Think about the cost of staying where you are, how that will play out over time if we keep doing the compulsions and staying where you are in your life versus what you want to go towards, the values. So that would be in our language, the sort of values and workability. So really thinking about why I would want to recover and what I would want to go towards and what it's costing me to stay where I am, even if I don't feel like have a choice about staying here, and it feels very difficult to make any changes, I'll try and get people to increase that reflection. And you can look at my YouTube channel, Jonny Say YouTube, for examples of motivation, reflection, values, connection, workability. I just put something up on crisis coping skills, and there's a lot of it in there, and other places. It's something to just reflect on a lot, and to really play out that workability, as painful as it is to think, okay, if I stay in this behavior pattern, what will that be like over the long run? And OCD is always giving that false comfort, right? It's saying, actually, no, it feels safer to do this. But if we're honest, that long-term picture, we're either losing out on the life we want to live, it's separating us from the people we love, and detaching us from people we care about. It's it's confusing us and reinforcing the OCD more, so we're getting actually worse in our symptoms, or we're getting a bit of comfort for a short period of time, but then OCD finds its way into the comfort zone, or depression finds its way into the comfort zone. So being really honest about that, and that it isn't keeping anyone safe, and it isn't it isn't what you would tell anyone else to do given your presentation. And so can we use that to try and make a change? And I bring in the sort of existential reality here, with the caveat of obviously thinking about people who are struggling with existential OCD or death anxiety. And, we might not rush to this there, but, really thinking about, this is my life, and it is going past fast, and I want to make the most of every moment. And I think if you can get in touch with that in a way that doesn't incapacitate you, but instead gets you fired up in terms of making changes, then that could be very helpful. So I think this whole, active reflection on workability, values and goals, the sort of recovery attitude. I used to think about recovery all the time when I was struggling. Before I made the changes, I was thinking about it all the time. And you could say, was that compulsive? Okay, sometimes it was, but sometimes it was more like an athlete or, high performer that's thinking about their topic all the time. I mean, I work with some, high performing athletes, and they're thinking about their sport all the time. Is that compulsive, or is that how they get themselves fired up, and how they learn, and how they motivate, and how they, really just build their skills when they're not actually doing the sport? So we have to be careful with it, that it doesn't become rumination about OCD and sort of meta OCD. But if it's more skill focused, goal focused, values focused, and it's motivating you to go and make some changes, I think, setting intentions, then that can be a helpful thing. And I thought about it all the time, to be honest.
Yeah, I agree. I did too. And I think, and I went in both those camps. Sometimes it was very much, skill focused. Okay, this is the skill I've learned this week. I'm going to try it every day. I might have a note in my phone, like when triggered, step 1, do this, step 2, do this, because I knew before I understood sort of upstairs, downstairs brain, I knew I couldn't cognitively remember it. So I made it simple. It was in my phone. I could go to there. I didn't need to think. It would remind me and I would action it. But then sometimes, I was just constantly re-listening to YouTube videos or reading certain articles, because every time I did it, I got a sense of relief, which was obviously a compulsion.
Yeah, exactly. And I did both as well. I did both. And I probably did way more of the compulsive version of this first, and then over time shifted it to more, targeted planning of how I'm going to use my skills when I'm triggered, and then reflecting on what went wrong if I got really pulled into it. Doing in DBT, they do like a chain analysis. So you really go chain by chain what happened. And I like that approach, doing that sort of thinking, so that next time, okay, how do I get my skills in? How is my mind resisting? What do I do in response to that resistance? So, those sorts of analysis is like an athlete and a coach looking at plays and analyzing, what happened and what they can learn and what they can do differently. But you're right. We've got to watch it isn't compulsive, and if in doubt, okay, assume it is compulsive and try to, response prevention or diffusion and focusing back to life. Let that rumination go where you can.
Just one other thing on that, because I think I think there are, in small doses, there's times that actually that little bit of reassurance, but I don't want to call it reassurance, I want to call it comfort. You know, if I occasionally read an article that makes me feel connected to a tribe or something like that, then awesome. It's when it just, I'm reading it every day because I can't get through the day without it.
Exactly. Yeah, we all need support. It's a better compulsion to do at a time of great difficulty, right? To have, I think of it, it's a bit like a methadone to come off the heroin of of the compulsions. It's okay, it'd be better to be doing a bit of listening to OCD content that it would be to be stuck doing compulsions all day, not even believing I can do any sort of recovery. But there comes a point, a lot of people have that point on the journey when you realize, okay, actually, I can let this go now, and I don't need to listen to all this content, and maybe I can just dip in a little bit to, once a week, up my motivation here. And the rest of the time, I listen to fun stuff and, the things I liked before I was struggling with OCD, or the things I think I could like if I wasn't struggling with it. And I had to go through that, and it was like an exposure, letting go of that content and starting to listen to comedy again or other things like that. My mind would be like, no, you got to figure this out, Johnny. You got to go back. Like, this is time wasted. What are you doing here, mate? You need to be on this stuff. And it was like, no, I don't. I know enough, to know where to work here. So yeah. The next two are sort of related. So one is just going, okay, ERP is too challenging right now. Let's build my skills. Let's have a few months where I just do skills. I try not to let OCD grow, try to not let it take over more territory, and I avoid more, or, more time spent ruminating or whatever. I try and keep that where it is and reduce it where possible. But I'm really working on skills, upping my attentional skills, my ability to focus when I'm triggered, my ability to have some distance and observe the intrusive thoughts, to let go of compulsions, to accept intense, overwhelming feelings, to surf urges, build all those skills. And you can look at my YouTube channel for my take on that. But there's lots of ways of doing it. You could be doing a DBT version, a metacognitive therapy version. There's different approaches there as well, but build up those muscles of psychological strength and flexibility so that you can then go back to ERP, with that. You think about, I thought about a client example here, and let's say that they're struggling with POCD, pedophile themed OCD, and they're really avoiding everything because they think the content of their thoughts is true and what their body's feeling is true. And so they've lost insight, they're avoiding, they're really staying inside a lot because of the intensity of the physical sensations and impulses and graphic images and judgmental, commanding, intrusive thoughts, that sort of thing. Okay, that's a lot to go out and face. If you made anyone's brain do that and you said, oh, just go do some exposure, that's an intense thing. So, okay, maybe we need a period of time strengthening up our skills so that then we can start to do the gradual exposure of calling OCD's bluff here and going, no, I'm the boss. My brain is just generating this stuff and I can choose how I respond to it. So, I was thinking of those sorts of examples where, just starting ERP seems impossible. Okay, build skills, get them really strong here. The other part of this was, for some people, where even building skills is very triggering. Some people are actually just sitting with their mind. They're getting such intense symptoms that it's hard to do that. So with these sorts of cases, I often think, okay, let's emphasize the RP part of ERP, and let's try to get life functioning as the E part, and try and not lose any areas of our life and try and push into it where we can, but at least don't let it grow. And then work on, developing the ACT skills during living life and doing the priorities and the places we face. So kind of behavior activation with the ACT skills, using the motivation, the compassion, other things as well. And you can look at that. I really go into this one in the crisis coping video I've done recently and other places as well. So it's like people that can't do ERP because it's too overwhelming, can't do skills because it's too overwhelming at this point. Okay, well, let's try to live life and practice. Dropping anchor for overwhelm is an act skill for that, where we're not really spending much time observing our thoughts. We're just briefly noticing what's going on, and we're getting into our body a lot more and engaging in cognitively demanding or physically demanding things. And try to work these sorts of skills and get that baseline up so that we're a little bit less afraid of the OCD, a little less like shut down and overwhelmed by it. And then, okay, then maybe we can start to practice skills, and then maybe we can start to do ERP. Yeah, were you going to say something to that one?
No, just that, well, yeah, I guess I am. That, yeah, in those situations, it could be really hard where the client doesn't feel ready for ERP, doesn't even want to do many sort of act skills. And like you're saying, okay, well, let's focus on living life and just doing something simple like dropping anchor while we do it to manage overwhelm. Yeah, it could be really hard with those clients, especially the population I see, the young clients, when they really don't want to do ERP or ACT or anything. It's then and I'm fine staying with the kids and the teens and well, I'm here as long as you need me. We'll keep trying to figure it out. I mean, sometimes you then get the pressure from the parents, whether they say it or not. You kind of feel it's there that I want to see my kid putting in the work. It's like sometimes,
and if they've read those outcomes, the way ERP's packaged, they think, well, why is it not doing it in 12 sessions like I read it should?
Yeah, exactly. And sometimes the work is there's a lot of legwork we're going to need to do here, or groundwork, before we can get to the gold standard interventions. Yeah, so it could be tough in those cases.
Yeah, and it's a lot of the behavioral activation ideas, and I tied to values and compassion and doing that kind of skill-based behavioral activation, but all the smallest achievable goal, building things like physical exercise. Let's really get yourself in a better state, fitness-wise, strength-wise, healthy lifestyle, meaningful hobbies. Let's pick them back up, even though you're not enjoying them, even though they're difficult. Let's try to, because, you'll have worked with clients like this, people who are having very intense symptoms, but somehow they keep their hobbies going, they keep exercise going. I mean, Jack, that we did episodes with Jack, was a great example of this, who's just great discipline for that side of his life. And he'll say it himself, it kept his head above water. It helped, but for some people, it's very difficult to do that sort of stuff. So we might need to use ACT skills with all of that, and urge surf the urge to not do those things. I was thinking of an ROCD example here, where someone's getting such intense ROCD symptoms that they're really starting to think, I need to leave, and the brain's even telling them that, and all the time they're threat monitoring everything they don't like about their partner and their feelings, and getting the wrong feelings, and what the pet partner says and looks like, and their mind might be judging, and that real intense ROCD where people have lost insight. Okay, well, that's, I'm thinking of a client there that might struggle to practice skills because all of this blows up, or ERP is even more scary because it might confirm, and be really intense. Okay, well, let's just go, what nurtures my relationship here? What are the behaviors I can do that are the actions of love? The behaviors that will be the healthiest stuff I can do. Let's do them and try to practice response prevention as I'm doing them, and try to use these skills in the moment. And yeah, it's going to be better if you do targeted practice and you do targeted ERP, but you can start to get your head above water, I think, by doing that, and then it becomes easier to do the other things. The next one is just go really heavy on self-compassion. Just switch completely to self-compassion and compassion-based work, radical self-compassion. It's not a feeling, it's a behavior, it's a choice in how we talk to ourselves, the behavior we choose to do, the people we connect to, where we put our attention, making that choice and training and practice and getting help, working with Kimberly's workbook is brilliant on self-compassion for OCD. And, I've got a lot of compassion stuff on my channel, and CFT, compassion focused therapy. There's lots of available books and ideas there. Really just going all out, emphasizing compassion practice. And you can see a shift. I've worked with clients. I worked with someone recently that worked so disciplinedly at compassion. He did such a good job of like, I see the rationale here. I'm just going to work it. It was before he worked with me. And he really shifted his relationship with himself and his self-talk. And he had a dramatic improvement in that self-compassion component, which then made other things easier and easier to do ERP. And, he worked so hard to do that. And I'll talk about people where it's impossible to do this work and it's hard to do even that. We'll give some ideas for that, because people might be going, well, I can't do that. But actually, I think everyone can do that. I've worked with people who were very stuck and weren't doing anything and then made the choice to start practicing and start doing this. So you can always flip that around and make that choice. It can be very hard to do it, but you can do it. And so, yeah, really just going all out on increasing self-compassion. And then particularly when people have shame, the OCD themes, the taboo thoughts, the stuff around sense of self, great shame about the compulsions and what OCD's driven them in the position that it's driven them into in their life, that kind of thing. Okay, let's try to work on compassion. And you're going to probably need to work with, you're going to need to work with a therapist, I would imagine, if you're in the types of clients I'm thinking of. But some people don't have access to therapists, and I have people writing to me from around the world where they can't access therapy like this, and they are working hard on their own recovery. And my heart goes out to those people in some really tough places in the world. And, but they're doing it. They're working on developing this self-compassion. And so you can do it in self-practice. Obviously, you want to access therapy if you can to do this. And sometimes going more into the history and trauma work alongside that, and trying different trauma approaches and compassion. I would, and even people without obvious trauma, we can just have a more sensitive nervous system that just means like some of the things in our life have just hit us harder. And I put myself in that category. Things that other people might not view as a trauma can just have left a big impact on our sense of self and our shame. And so working on it, even if there's no obvious trauma as well. I think related to this is switching the focus onto relationships. So this is something that I learned a lot from Nate, who we've got coming in and doing a training at the center on functional analytics psychotherapy for therapists. He talked about with me about, you can, with some clients, when you've tried this progression of ERP and ACT and, maybe some other approaches as well, just switching to go like, what is this person's relationships like in their life? Where are they disconnected? What are the behaviors that are disconnecting them? What are the behaviors that are connecting them, or we need to do more of them? How can we build ERP around connection, even if we don't call it ERP? But, let's set measurable goals around increasing social connection and improving how we relate and connect to people. And for some people, it's going to be, they're very disconnected, and it's finding groups and starting from scratch. And then other people are connected, but they feel disconnected. So how do we, maybe change what they're sharing, where they're vulnerable, where they're not with people, how to increase that sort of intimacy and social connection. Some people are connected, but they're connected to people that are taking advantage, and it's more boundaries and actually finding allies and getting distance. And then other people are highly connected, but OCD is disconnecting them. So, bringing the skills into that connection more. So I think, social connection can be just such an awesome place to work if you're having difficulties with everything else. And I do think, even if you can't shift the OCD symptoms, if you improve your social connection, your mental health's going to be in a better place, baseline. It might become easier to do ERP again. You've actually done ERP because you've had to go and speak to people and do stuff and do scary things. Yeah. So I think this can be really helpful, and especially if you've got the kind of shame stuff again, that's telling you I'm not worthy, I shouldn't, no one wants to connect with me. If they knew what was going on in my head, well, actually, the ultimate exposure is starting to connect with people. Or on the other hand, the OCD disconnects you because of the compulsions and the behaviors it's doing. Okay, well, let's try to let go of some of that and connect a bit more, and let go of some of the rumination and actually think about social connections day to day more than ruminate about OCD.
Well, exactly. It gives you something to focus on that is productive, that is hopefully going to make a difference to your life, and increasing social connection is a protective factor. So it's going to keep you safe or more safe. Yeah.
Completely.
And
antidepressant, it's antidepressant it won't feel like that. When I was working on this in my recovery, I felt more depressed when I met with people to begin with, and my mind would be saying, this isn't working, you feel awful, you don't feel connected to this person, they don't want to see you, blah blah blah. Okay, we're going to cut through all that noise with our skills and still connect, and give it some time, like you would with an antidepressant. You have to give it time to work. Okay, we need to give it time to be helpful, and eventually your brain won't try and unpick everything that you're doing that's positive for your recovery. So I think functional analytics psychotherapy, I think, is a great place for that. The sort of social side of ACT, putting values, relational application of values and skills. There's lots of stuff out there, lots of therapies. I think you were telling me about Irvin Yalom's new book. I was just started reading that. I mean, the depth of connection in that. These single sessions he's dealing with people, and how do you be intimate and honest and vulnerable with people, and how do you connect? I mean, I think he's got a lot of good stuff to say. Maybe not on OCD symptomology, but certainly on how to deepen your connection with people. There's lots of ways of doing this, and lots of you in the UK system, there's lots of evidence-based treatments recommended by NICE that specifically focus on relationship. So you can look into those, the sort of NICE-based National Institute for Clinical Excellence recommended treatments for, relationships and interpersonal stuff. And there's lots of stuff there. In America, they've obviously got lots of evidence-based stuff on working on interpersonal connection as well. And then the final one that I wanted to cover is, if all of this is blocked, if you can't do any of this, and like this person, so I'm thinking of clients where, for whatever reason, inpatient isn't an option. Obviously, that would be the first place to go. Try to access inpatient or intensive outpatient or more intense treatment, or join in recovery communities and peer support and other things, and try to just increase the help you're getting. But that isn't always available. In the UK, it can be very hard to access those services. And some of those people will still come to therapy. So especially with Zoom, they show up to therapy regularly, but then they find it very difficult to just do anything because of the depression shutting them down, or just the way OCD blocks everything they try to do, what I call secondary spikes or resistance. You try and do anything, it resists it. And I think, for these sorts of clients, again, everything I've said above would be applicable, and you could try all those things. But I like these two ideas from Dropping Anchor, the ACT skill that I use a lot. So you have Dropping Anchor, waking up the body, and Dropping Anchor for overwhelm. And you can look at both those on Jonny Say YouTube channel for the way of doing it. But it's trying to get the body gradually activated, and I think of it sometimes like when someone wakes up with sleep paralysis and you can still move your eyes. That's the one thing you can do. And once you move your eyes, then the rest of your body starts to wake up. It's a bit like that. So you're in that absolute shutdown state. Assuming you're not completely shut down and you need a therapist to be doing this with you, there's some degree of, like, you can move your eyes, you can wiggle your fingers and toes, you can start to wake up the body piece by piece and each joint. And then once you're moving, you can then start to get out of bed. You can coach yourself through that. You can be saying, I had to do this. I didn't fall into it because I knew what was happening when it was happening to me, but I had the urge to do all of that. And I would be coaching, I'd be waking up my body, I'd be coaching myself through it, saying, Johnny, all you have to do is stand up. Okay, walk out of your room. You got this. Well done. Okay, go and get a glass of water. Brilliant. Fantastic. Right. Go out of the house. Go for a walk. Coaching yourself through it as well. Now, there's a lot of ideas here, and you definitely look at my YouTube channel for some of these ideas under the OCD skills playlist, or the crisis coping stuff I've done recently, other places to go in more detail. We obviously can't cover it all today. But you do all of these things. Hopefully you repeat it in session. You do some mental rehearsal of when these episodes happen. So you imagine getting into that stuck down state and using your skills like an athlete. You rehearse what it would be like to work your recovery skills there. You're dropping anchor for overwhelm, waking up the body, you're compassionate inner coach, you're urge surfing, shut down inactivity, all these things. And then sometimes I find I've worked with people that can't, you do all of this, they still can't do it. And what I find with those people, if they're coming to therapy, there's some motivation, right?
Yeah.
And so I find that they normally can at least start to observe what's going on. They can do that move of like, I'll observe the intrusive thoughts and the commands to not do anything, and stay in bed. I can observe the heavy, fatigued, shut down feeling, dissociated, numb, whatever it's like, depressive feeling, or blended with anxiety. I can observe all of that. I can, start to get some distance. And what you find is if people do that enough over time, you suddenly hit a day when there's enough distance. You go, I can move my body. I can start to get activated and out of this place. And I worked with a client once who, she came to me, she'd been very suicidal, made active suicide attempts, was really stuck in a depressive state. She wasn't an OCD client. She was a different presentation, more depression. But we just did this stuff. We did like, okay, you can't practice anything. Okay, let's just observe it. Let's practice that move. I did stuff with her in session, and then let's just observe it. And then there was 1 week I came, and different person, looked completely different, up, moving around. She was like, I just felt like I got enough distance that I could then get up, get moving. Then I started going for a walk. Then I did this behavior, that behavior, and it rolled on into more behaviors. So sometimes, and I'm not saying any of these things are magic bullets or that they work for everyone, and that there's nothing like that. I'm not painting like I've got some sort of secret formula. A lot of this stuff, you find it in any good therapist toolkit are going to do similar things. But if you really work hard at that, you can have these moments where suddenly, actually my brain could be saying one thing and I can do whatever the hell I choose, which is what we want to be able to do for OCD, right? As well as depression. So that I wanted to get that point across, because there will be people listening to this that are in that place, because they reach out to me and I've heard from these people many times. And, let's at least start to try and get some distance and some diffusion going on, and then see if you can wake up the body, see if you can start coaching yourself into action, and see if it can build from there. And then you could have this wonderful place. And I have seen this with people where, you move out of that depression using those sort of crisis coping, overwhelm skills. You then start to be able to practice ACT skills daily or most days of the week. You then start being able to do ERP. You then start being able to do more challenging ERP, and then you're into it, but without that foundation, the person wouldn't have engaged. So that's obviously an ideal case. Most of the time it's a much more of a roller coaster than that. But yeah, I wanted to put those ideas out there.
Idea for therapy. Change will happen, but it will take time. But it will happen is the key point in that sentence. And we can think about sometimes time. Well, I haven't got time. It's too hard day to day. But we can all look back in our lives and be like, oh, what felt like an eternity 5 years ago? When I look back, feel like it went in a click of a finger.
Oh yeah.
And I see that so many times with my clients. Sometimes I feel hopeless and helpless. How am I going to help? This is beyond my skill set and da 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 da. But sure enough, eventually it changes.
Yeah,
it happened, but it took time.
Yeah.
And how
And it
long is that
doesn't
time? It varies per person.
exactly. And people listening to this that are in that place will, think that you just can't believe that when you're stuck in the pain, the
Mm-hmm.
pit of pain. But it does. I've gone back to some because I did a lot of compulsive journaling of symptoms, and a lot of got hundreds of emails that I sent to myself and all kinds of things like that. And when I can't even remember some of the things my brain was doing unless I look at those. It feels like a blink of an eye, that period of my life now. Whereas actually it was at least, this 7 years of working on recovery. And again, it shouldn't take that long. It doesn't have to take that long. But, that even that 7 years doesn't feel very long when I think about it now. And obviously it was, it wasn't the intense difficulty. The intense difficulty was probably building up over a year and lasting over, the worst phase for me was sort of building up and getting worse over that year and then going out, probably another year or so. But that seems like a blink of an eye now. So you do get out of there and you forget how bad it was. And what we want to do is we don't want to hit the worst pain to motivate change. Everything I've talked about today is trying to get there sooner so you don't have to hit the worst pain to then get you to make some changes. We want to try and use reflection. We want to try and use skills, different grading of skills and ERP and practice so that you don't have to hit that painful place. But it will happen. And, my good old favorite phrase, gentle relentlessness. You just got to keep going. And, it's like, again, the sports analogy. People often have fired 3 or 4 coaches before they found the right coach that got them to excel and be, the best athlete they could be. And sometimes you have to work through different therapists, and, good therapists will understand that. And you don't want to let that be I've got to find my therapist immediately as soon as anything's hard. Obviously, we've got to persist. You've got to listen and give it a shot. And, but if you are feeling stuck, we can't write off everyone because of a bad experience. You've got to look around and talk to some people and see if there's anyone that's approach feels different. But change will happen. I like that.
Yeah, absolutely. Well, look, thank you so much for talking about this topic and being, clarifying the points, being clear with them. I think it's given people hopefully actionable ideas to think about.
Yeah, and look at my YouTube channel for, further expansion on all these sorts of ideas. Yeah, that's great.
I'll put a link in the show notes. But if people don't want to go to the show notes, what would they Google on YouTube?
Jonny Say Therapy, Jonny Say Therapy on YouTube and Instagram. We've obviously got the Integrative Centre Instagram as well. So that's where I put perhaps more of the specific OCD content, but there's a lot on my Instagram as well. So YouTube as well. I'm trying to put a lot of stuff up.
Thank you for listening to this week's podcast, and thank you to our Patreons who helped make this episode possible. And if you would like to find out more about Patreon and the rewards and benefits, then there will be a link in the episode description. If you enjoy the OCD Stories podcast and would like to support us, please subscribe and rate the show wherever you listen to the podcast. And thank you to NoCD for supporting our work. And if you want to find out more about NoCD, you can click the link in the episode description. And quick disclaimer, guys, this podcast is not therapy. It is not a replacement for therapy. Please seek treatment from a trained professional. And until we speak, take care.